Hello, wonderful staff of the Northwest Kidney Center. As usual, I'd like to begin with a shout out to the awesome staff of the 5-star Kent Northwest Kidney Center facility. You all are awesome. And an additional shout out to our sister unit in Panther Lake where the care is nearly as good. Today we're going to talk about bone disease in dialysis patients. This is a ubiquitous problem in the dialysis world as kidney disease negatively impacts bone health. Most of our dialysis patients do not have healthy bone, and it predisposes them to fractures and loss of height, among other problems. There are 3 objectives to today's talk. I want you to understand the types of bone disease seen in dialysis patients, recognize the clinical presentation of bone disease, and review treatment options. In order to understand the bone disease that affects kidney patients, it's important to understand normal bone health. If you've ever owned a car, you recognize that a car needs constant care. Something breaks and needs to be fixed. Similarly, a house is never completely finished. Something is always breaking and in need of repair. And if you do a lot of fixing in the house, we call it a remodel. Now, our skeletal system is similar. It is constantly being broken down and built up again. And just like a house, we call this process remodeling. Remodeling is a dynamic process in which bone is constantly being broken down and replaced. Or phrased another way, normal bone metabolism relies on a balance between bone turnover and formation. This is what gives bone its strength. Bone is constantly being broken down by cells called osteoclasts. These are the Pac-Man-like cells of the bone that chew it up and release calcium and phosphorus into the blood. It is also being built up again into new replacement bone by cells called osteoblasts. Osteoclasts and osteoblasts work together to remodel bone. After osteoblasts have put down new bone, it needs to be mineralized. Mineralization is a process by which osteoid, which is the unmineralized organic component of bone that's produced by osteoblasts, becomes calcified. This process depends on adequate levels of calcium, phosphorus, and vitamin D. And again, it's very important to deposit calcium in the osteoid because that's what gives bone its strength. Bone mass is a measure of bone tissue present in the end of skeletal maturity. It represents both its volume and its size as well as the density of the mineralized tissue. Peak bone mass occurs in the hip between ages of 16 and 25. It's greater in men and in African Americans. After we reach the age of skeletal maturity, we then lose some bone every year thereafter, about 0.3 to 0.5%, until, in women at least, they reach 6 to 10 years after menopause when bone loss is accelerated at 2 to 3% per year, at least in women that are not treated. And the rate of bone loss can be modulated by structural and metabolic factors. So for example, if you do weight-bearing exercise, you can increase your bone density and mitigate bone loss. With that as background, let's now turn our attention to bone disease in dialysis patients. Virtually all dialysis patients have bone disease, and we'll discuss why that is shortly. Many of our dialysis patients, for example, have curved spines, if you look at them from the lateral view, and it's common for our patients to be hospitalized with fractures. So this is a clinically important problem. Bone disease in dialysis patients is called renal osteodystrophy, and there are a lot of medical terms that are confusing, so I like to break them down into their roots so you can understand them better. Renal refers to kidney, osteo is a Greek word for bone, dys is the Greek word for bad, and trophy is the Latin word for nourishment. So literally, renal osteodystrophy means badly nourished bone. You may have also heard the term chronic kidney disease mineral bone disorder, or CKD-MBD. This is a broader term that includes both bone disease as well as cardiovascular disease that stems from an imbalance of minerals and hormones such as calcium, phosphorus, and parathyroid hormone. Today we're going to focus just on the bone disease in dialysis patients or the renal osteodystrophy rather than the cardiovascular complications. Renal osteodystrophy is present in most patients with kidney disease. It can weaken bone and cause bone pain and fractures. There are several different types of renal osteodystrophy, and we'll go through these each in detail, but they include osteitis fibrosa cystica, which occurs on the basis of having excess parathyroid hormone, or osteomalacia, which is due to a failure to mineralize the bone, usually secondary to vitamin D deficiency. You can have something called adynamic bone disease, where the bone tissue doesn't renew itself as it should, usually because PTH levels are too low. And of course, you can have a mixed picture, like you can have both osteoitis fibrosa and osteomalacia. So again, we'll go through all these individually. The first and most common type of bone disease seen in dialysis patients is something called osteitis fibrosa cystica. Osteitis means inflammation of the bone. Fibrosa means containing fibrous tissue or scar. Cystica means containing cysts. So osteitis fibrosa cystica means inflamed, scarred, cyst-containing bone. It's just a pathologic term used to describe how the bone looks, the morphologic bone changes seen in this condition. It's also known by an easier term called high turnover bone disease. And I like this term because it offers a clue as to the underlying physiology. The bone is remodeling too rapidly. Specifically, bone is being broken down, then replaced too quickly, and most of this is driven by parathyroid hormone, or PTH. What is parathyroid hormone? In the neck are located 4 small glands called parathyroid glands. They produce a hormone called parathyroid hormone, or PTH. Purpose of parathyroid hormone is to regulate serum calcium and phosphorus levels. And there are several triggers for PTH release from the parathyroid glands, including low calcium and vitamin D levels, as well as high phosphorus levels. If your calcium level is running a little bit low, let's say you didn't drink your usual cup of milk in the morning, the low level is sensed by the parathyroid glands, which in turn release parathyroid hormone, which activates osteoclasts in the bone, releasing calcium and phosphorus from the bone. Also acts on the kidney to increase calcium reabsorption and phosphorus excretion. Also stimulates the production of activated vitamin D, which assists in the absorption of calcium from the blood. So this hormone cascade all serves to increase calcium levels. That's the main function of parathyroid hormone, maintain normal serum calcium levels. Sometimes the parathyroid glands are overactive and produce too much parathyroid hormone. We call this hyperparathyroidism. Overactivity of the parathyroid glands resulting in excessive production of parathyroid hormone. Typically, this occurs when one or more of the glands undergoes what's called hyperplasia. The cells divide, creating more cells. This illustration here shows how a normal parathyroid gland on the left can over time increase in size with the development of parathyroid gland hyperplasia, so more cells are produced. In this case, on the right side, there is one single nodule, and that reflects an increase in size of the parathyroid gland, and that parathyroid gland will produce too much parathyroid hormone. If this process happens independent of an external trigger, we call it primary hyperparathyroidism, which results from hyperfunction of one or more of the parathyroid glands themselves. There's oversecretion of PTH, say due to a nodule or hyperplasia, or rarely even cancer of the parathyroid glands. It was first described by a physician at Mass General in Boston named Fuller Albright, who actually made many endocrine discoveries, including hyperparathyroidism. Unfortunately, he developed Parkinson's disease at the age of 37, had experimental brain surgery at the age of 56, led to a stroke, and he was comatose the last 13 years of his life. The first documented case of hyperparathyroidism, 7,000 years ago in Germany, a 25 to 35-year-old woman from an early Neolithic cemetery in Germany was found to have classic skeletal findings of hyperparathyroidism. You see a whole bunch of salt and pepper dark spots in the skull, and that represents a reabsorption of the bone as a consequence of hyperparathyroidism. While primary hyperparathyroidism can occur in dialysis patients, a much more common entity that we see in our dialysis population is something called secondary hyperparathyroidism. It is due to an elevation in parathyroid hormone from a physiologic trigger that causes the parathyroid glands to release their hormone. Most often that is low calcium levels, so hypocalcemia is the main trigger, but there are other triggers as well, including vitamin D deficiency, a high phosphorus level, and of course renal failure. PTH cells can multiply under these circumstances but are slow to regress, and sometimes the growth or hyperplasia of these cells is irreversible. A normal parathyroid hormone for someone with normal kidney function is maybe ballpark 10 to 50. In a dialysis patient, an acceptable PTH range is considered to be 2 to 9 times the upper limit of normal for the assay, which is ballpark 100 to 450 picograms per milliliter. If the secondary hyperparathyroidism goes on for a long time, it can oftentimes evolve into something called tertiary hyperparathyroidism. Tertiary hyperparathyroidism is basically reflects irreversible hyperplasia of the parathyroid glands and loss of response to serum calcium levels. It's most often seen in dialysis patients who have been on dialysis for a long time, and it represents an autonomous activity, meaning that the glands are producing parathyroid hormone regardless of stimuli such as low calcium or high phosphorus levels. The second type of bone disease that we see in dialysis patients is sort of the opposite of high turnover bone disease. It is called adynamic bone disease, also known as low turnover bone disease. So sometimes the bone remodeling process is too slow. The main cause is excess calcium and vitamin D, which we administer to our dialysis patients in order to lower their phosphorus and lower their parathyroid hormones. But if we suppress the parathyroid hormone production or release too much, that is, if the PTH levels get too low, we suppress bone turnover. And that leads to, again, adynamic bone disease. Adynamic bone is structurally weak because, again, remodeling is needed to strengthen bone. It is more commonly seen in peritoneal dialysis patients and hemodialysis patients, and more common among diabetics. The third type of bone disease that we see in dialysis patients is called osteomalacia. Osteo, again, is a Greek word for bone. Malacia is a Greek word for soft, so osteomalacia means soft bone. As I mentioned earlier, this occurs if the newly formed organic bone, or osteoid, that is made by the osteoblasts fails to mineralize or calcify. The calcium deposition adds strength to the bone, so unmineralized bone is weak and prone to fracture. The most common cause of osteomalacia is vitamin D deficiency. If osteomalacia occurs during childhood, it can cause a condition known as rickets, which most often occurs because of extreme and prolonged vitamin D deficiency. If kids don't get enough vitamin D, they can't absorb enough calcium and phosphorus in their food, and they don't mineralize their osteoid or the newly formed bone. The bone is so soft that microfractures occur, leading to bowing of the bows as demonstrated in this picture. Other causes of osteomalacia in dialysis patients include heavy metal toxicity such as aluminum, which can enter the blood of dialysis patients through dialysis if water is not processed properly or if we use aluminum-based dietary phosphorus binders. Okay, let's now turn our attention to the clinical presentation of renal osteodystrophy. Patients may present with bone aches, particularly in their lower back, their pelvis, their legs, or their ribs. Patients may lose height because of the development of compression fractures. Compression fractures occur when a vertebral body collapses, making them shorter in height, and sometimes a piece of bone can press on the spinal cord and cause nerve damage or pain. Children with kidney disease may experience stunted growth because of the renal osteodystrophy. But the most important clinical manifestation of renal bone disease is fracture. Fracture is increased among patients who are on dialysis compared to patients with chronic kidney disease, and certainly greater than in the general population. This is a retrospective review of the Swedish Renal Registry from 2020, looked at over 9,000 patients between 2005 and 2015. And they found that the crude incidence rate of a major fracture in a patient prior to starting dialysis was 17 per 1,000 patient years, whereas after dialysis initiation, it was 24 per 1,000 patient years. Nearly all dialysis patients have bone disease, But how do you know which kind they have? I mean, do they have low turnover? Do they have high turnover? Do they have osteomalacia or a combination thereof? There are some diagnostic tests that are suggestive. For example, we could do blood tests. We can measure their calcium, their phosphorus, their vitamin D, and their parathyroid hormone levels. A PTH that is 9 times above the reference range. So let's say, for example, the upper reference range is 50 picograms per mil, so 9 times that is 450. So above 450 has an 87% specificity for high turnover bone disease. In contrast, a low PTH level, say of less than 150, is more suggestive of low turnover bone disease. We can do a bone density test called a DEXA scan that'll measure the density of the bone, but it's not useful for distinguishing the type of bone disease. There are other imaging tests that are available, X-rays and CAT scans and MRIs to assess bone changes. But the gold standard is something called a bone biopsy. Basically involves taking a drill into the pelvic bone and taking a small sample of tissue, which we send for laboratory analysis. And it can tell us exactly whether they've got low turnover, high turnover, or osteomalacia. But it's rarely done because it's invasive, it hurts, and it's expensive. How do we manage renal bone disease? Well, treatment depends on the extent of bone damage and whether bone turnover is high or low. Diet is the first line of defense. It's very important for patients to follow a low phosphorus diet because phosphorus levels stimulate the release of parathyroid hormone and increase the risk of high turnover bone disease. If someone has an elevated PTH level and we suspect that they have high turnover bone disease, we may prescribe a medication called cinacalcet or Sensipar. This is a class of medicine that belongs to a family known as calcimimetics. These medications mimic the effect of calcium at the parathyroid hormone receptor. They bind to the calcium-sensing receptors on the parathyroid glands, and the receptor then thinks that there is sufficient calcium in the blood and then reduces the secretion of parathyroid hormone. Medication is used typically to treat secondary hyperparathyroidism. Cinacalcet or Sensipar is generally well tolerated. Common side effects include nausea and vomiting. You can also see low calcium or hypocalcemia. And if you lower the parathyroid hormone too much, then you can cause adynamic bone disease. Some dialysis patients develop markedly elevated PTH levels, often associated with high calcium levels or hypercalcemia, and this is called tertiary hyperparathyroidism. The glands become so big and active that they can no longer be suppressed with usual medical management, such as administration of vitamin D or a phosphorus reduction or administration of cinacalcet or Sensipar. In this case, the patients may be referred for a surgical procedure called a subtotal parathyroidectomy. This involves the excision of all identifiable parathyroid tissue, except for a small little bit, maybe 40-60 milligrams, of the least hyperplastic glands. We'll take out basically 3.5 of the glands. And the procedure works well. Immediately, the PTH levels fall, but there are some drawbacks. Substantial risk of persistent recurrent disease, particularly if they are on dialysis for another 5 years after the procedure and they need to have a second surgery. There's also the risk of low calcium, permanently low blood calcium levels, or hypocalcemia if too much tissue is removed. There may be a survival benefit for dialysis patients who undergo subtotal parathyroidectomy. Brian Kestenbaum, a nephrologist at Harborview, published a study in 2004 looking at survival following parathyroidectomy. It's an observational matched cohort trial of about 4,500 dialysis patients underwent parathyroidectomy and were compared to the same number of controls who did not undergo parathyroidectomy. And he reported that the long-term relative risk of death was 10 to 50% lower than those matched control patients who did not undergo surgery. Sharma published a study in 2012, looked at 150 dialysis patients who underwent a parathyroidectomy and were compared to 1,000 matched controls who did not undergo the surgery. The mean PTH value among the parathyroidectomy cohort was 1770, which is very high, and the mean follow-up was 3.6 years. And he also reported that parathyroidectomy was associated with decreased mortality. These are not perfect studies. They are observational studies. The best they can do is establish association. And so it's not definitive that parathyroidectomy has a survival benefit. All right, now let's summarize what we've learned today. Renal osteodystrophy is the broad medical term for bone disease seen in patients with kidney disease. Remodeling is the process by which bone is constantly being broken down and reformed and is important for proper bone health and strength. Bone remodeling is usually abnormal in dialysis patients. There are 3 types of bone disease seen in dialysis patients: osteitis fibrosis cystica, or high turnover bone disease, adynamic bone disease, which is also called low turnover bone disease, and finally osteomalacia, or abnormal bone mineralization, and patients can have combinations thereof. Parathyroid hormone is an important hormone that stimulates bone remodeling. Excess parathyroid hormone leads to high turnover bone disease, and insufficient PTH leads to low turnover bone disease. Osteomalacia in a dialysis patient is most often due to vitamin D deficiency. If parathyroid glands are overactive in a dialysis patient, we diagnose secondary hyperparathyroidism. If PTH production remains overactive despite medical management, including administration of vitamin D and cinecalcet or Sensipar, and a patient develops hypercalcemia, then we say that they have tertiary hyperparathyroidism, and that patient would likely benefit from a subtotal parathyroidectomy. Time for the monthly quiz. Question number 1, what are the 3 main types of bone disease seen in dialysis patients? That's right. High turnover bone disease, or osteitis fibrosis cystica, low turnover bone disease, or adynamic bone disease, and osteomalacia, or failure to mineralize bone. Question number 2, osteomalacia, or failure to mineralize or harden bone, is most often due to That's right, vitamin D deficiency. And again, if that occurs in children, they can develop very soft bone that's prone to microfractures, and they can develop bowing of their legs called rickets. Question number 3, the most common cause of low turnover bone or adynamic bone disease in dialysis patients is? That's right, so overtreatment with calcium and vitamin D. So again, we use a lot of calcium-based binders, and we give a lot of vitamin D, and that can suppress the PTH and contribute to adynamic bone disease. Now, you can still have adynamic bone disease independent of medication administration, but we certainly don't want to contribute to the problem. Question number 4, what is the gold standard test for clarifying the type of bone disease present in a dialysis patient? That's right, a bone biopsy. Bone biopsies are available but rarely done. They're expensive and invasive, and patients generally don't like to undergo them. Final question, what are the clinical signs and symptoms of renal bone disease? That's right, bone pain and fractures. Those fractures, again, can occur in the extremities. They can occur in the vertebral bodies, leading to loss of height. This concludes the March 2024 in-service for the Northwest Kidney Center. Thank you so much for your attention and for the wonderful care you provide our patients. This is Andy Borkenbrough signing out until next month. Hope you have a great start to your spring.